Gentle disclaimer to all of our listeners. All medical information mentioned in this podcast is purely informational. It is not individualized medical advice. Please follow up with your physician or medical practitioner for individualized care specific to your needs. Thank you.
Hello, everyone, and welcome to the Know and Do Better podcast. My name is Dr. Melanie Carminati, and I am excited for our chat today about SIBO. We'll be talking with Dr. Elena Ivanina. And so, Dr. Ivanina, thank you so much for your time. Thank you for being here.
Thank you so much for having me.
A very interesting topic because I have a handful of patients who have SIBO or have had SIBO. I want to start off just with introducing Dr. Ivanina for those who are unfamiliar with her. Dr. Ivanina completed her medical school training at New York College of Osteopathic Medicine, where she learned about a more holistic approach to medicine. She received her MPH at Columbia University and concentrated on a population health approach to GI cancer prevention and received a grant from the American Cancer Society. Afterwards, she came to Lenox Hill Hospital for her GI fellowship and has been there ever since as the director of neurogastroenterology and motility. She specializes in an integrative and nutritional approach to GI conditions, the microbiome, motility, and disorders of the gut-brain interaction with training in functional medicine as well. So Dr. Ivanina, thank you so much. I want to start off with simply just explaining what is SIBO.
SIBO, or small intestinal bacterial overgrowth, I like to describe it as a dysbiosis, right? It is a change from the normal microbiome in your gut, right? Your gut is full of trillions of microbes. It's actually full of bacteria, viruses, and fungi, which are all normal and actually really beneficial in most cases to be there. And specifically, SIBO is when something causes a shift in that normal milieu, if you will, of your bacteria. And then it basically will produce a gas that then produces you to have GI symptoms.
So what are some of the symptoms that patients with SIBO might present with?
There are actually 3 types of SIBO now. The oldest is hydrogen dominant SIBO. That one actually can have either diarrhea or constipation. Then there is methane overgrowth. So that's actually not even called SIBO anymore. It's called IMO, or intestinal methanogen overgrowth, because it can happen anywhere in the gut, not just in the small bowel. And then that produces constipation because methane gas constipating, that's been shown in studies. And then the newest kid on the block is hydrogen sulfide SIBO. So hydrogen sulfide is a gas that we're only recently now testing for, and that one produces diarrhea. All 3 of them, in addition to the change in bowel movements that I just described, all 3 of them also are famous for producing bloating, food intolerances, and then pretty much anything from acid reflux to, honestly, systemic changes in the body, such as rashes, joint pain, brain fog, a lot of things. That's usually through kind of that leaky gut intestinal permeability phenomenon.
So with those 3 types, I guess each of them has a different cause or something that triggers it. Can you touch on it maybe generally or specifically, however you think? The
most classic SIBO is that hydrogen SIBO, which is the one we know the most about. So basically, most of your microbiome is in your colon. That's normal. Most of the gut bacteria is localized in your colon, and that's where it ferments. What's left of your food after it's gone through your small intestine produces gases there, and that's normal. But there can be times, conditions, other risk factors that cause the microbiome to then grow up into the small intestine where it shouldn't be, past the ileocecal valve. And that is the condition where then you have these bugs in a place they shouldn't, producing gas when the food hits them before it actually hits the colon. So what causes that shift for the microbiome to be in the places it shouldn't? In the case of hydrogen SIBO, or in the others, just again, a shift from normal. There's a whole list of things. And the biggest thing I see is usually it comes down to motility. That motility can be from many different sources. It can be dysfunctional motility from what we call outlet obstruction or pelvic floor dysfunction or dysenergic defecation. It can be a intrinsic issue with the actual nerves of the colon or small bowel, or it could be something like food poisoning. Many cases, especially after something like Campylobacter jejuni, causes a autoimmune reaction in your small bowel where you actually produce an antibody that injures your small bowel motility and specifically the migrating motor complex, or what we call the MMC. And that again is, mostly motility oriented, of why things are just not in the colon where they should be, but are able to grow back and create dysbiosis.
So it could be a few things. So how do you go about treating? What's like the most effective treatment for the different types of SIBO?
Sure. So in the general treatment of SIBO, the most important thing is to touch upon 3 tenets of SIBO treatment. And the first one is going to be root cause evaluation. The second one is going to be induction antibiotics or antimicrobials. And the third is maintenance, like maintenance phase. So that's going to be usually something like a prokinetic. Each one is treated a little differently, as again, they produce different symptoms. And for example, there's a lot of details to get into, but for example, the methane overgrowth, it's not even just bacteria, it's also these archaea, these single-celled organisms that produce it. So you have to have a different approach when it comes to treating each of them because they're very unique. So again, the root cause evaluation is a lot of times a motility workup. So, again, if they have constipation, we're doing anorectal manometry, we're doing smart pill to investigate their stomach, small bowel, and colon motility. We're looking at IBS smart testing to see if they have that antibody after having infection, a gut infection. And there are a whole bunch of other things. We look for autoimmune conditions. We, obviously want to make sure the patients aren't taking a medication or something that is causing this. There are a whole laundry list of things to do, but you can't really defeat SIBO unless you've actually addressed the root cause. And then the induction is, what you're actually addressing the overgrowth with, and that could be either antibiotic or herbal antimicrobials and, different supplements like allicin and garlic. And then finally, the prokinetic, the last stage, the maintenance phase, that again is in most cases just about, again, optimizing motility. And it could be a pharmaceutical prokinetic or an herbal prokinetic. And then again, maintaining what it is that you need, to improve your motility. For example, a pelvic floor therapy.
For myself, as a pelvic floor physical therapist who uses visceral manipulation, when we talk about motility, we're talking about that innate movement that is in our organs or should be in the organs. Many times there's either a restriction or different speeds, I guess, of how the organs are moving. So that's how I think of motility.
It's really, as you described, it's the forward movement and propulsion of the contents of the gut, which change from every segment. So it's sphincter related. So from the upper esophageal sphincter to the pylorus to the ileocecal valve to the anal sphincter, those are definitely absolutely key in controlling proper motility and assessing their function, which again, definitely is difficult to do in many cases. But then there's also intrinsic motility of the actual gut wall, which usually involves the motor neurons, and that's controlled mostly by serotonin. And then there are things like motility of the colon, for example. We do a SITS marker study, and we see that usually the markers are held up on the left side. And that's constipation. That's a motility issue, but it's usually due again to what we call an outlet obstruction or something that is usually pelvic floor related, that they're all ending up on the left side. And even though the motility of the colon is intact, they're not evacuated appropriately. So it's multidimensional. It's a lot.
Yeah, as a dancer too, I think of it like the gut is just like each segment has its own kind of choreography, but it's all working in synchrony.
Yeah.
So each segment has its own motility and innate movement, but it's all working together.
That's a beautiful way to think of it.
When you're diagnosed with SIBO, do you end up having it for life? Do you have to manage the symptoms indefinitely? How does it work?
So there's a range for sure. Part of it has to do with your root cause. There are people who probably get kind of transient SIBO. They may feel, bloated after an infection, after a gut infection, after the acute infection, have some altered bowel movements, some bloating, and then they'll get back to their normal. So I think it really is a range from it being a transient issue to one that kind of sets up shop and finds its, again, like milieu, like in the gut, it's new homeostasis. And so that you have to then, again, those symptoms are persistent, but when you address it, you address the root cause, you do the induction and the maintenance, then people have really great outcomes. And then there is a handful of, there are a handful of patients that have issues that lead to chronic SIBO. And it's very difficult and can definitely necessitate, basically maintenance induction. And most common, I'd say the two reasons I see it very chronically, the most common, ileocecal valve resection, as you could imagine. And then I also see it with bariatric surgery, bypass.
Okay.
But those types of just huge there's so much anatomic dysfunction there. And I'm sure, you see that, like how do you control things without an ileocecal valve, right? It's hard to imagine.
When I'm working with my patients who have SIBO and we're doing visceral manipulation, because I typically do it in combination with craniosacral therapy many times just to facilitate a parasympathetic mode for the patient, because as you know, that brain-gut connection, having SIBO present, I find that a lot of people are just in that sympathetic overdrive also from that. So kind of facilitating it from there and then getting down to the gut and working through the sphincters, it's interesting to feel at the start of the session and then at the end of the session the difference in the motility, the sphincters, even just in the mesentery itself, just being able to feel that. So what is the current research saying for SIBO? Is there any new findings or treatments that are on the horizon? Or
I think there's always something being investigated. I think there's going to be a lot that comes out with SIBO sulfide, right? This new hydrogen SIBO, because this is brand new. I mean, we just started testing for this recently, and it's not even, there are ways to treat it. There are things that you can add to help control sulfur gas, which is a very foul-smelling gas. Patients usually can definitely tell you when they have rotten egg or sulfur-smelling gas. In most cases, again, there's usually something like, for example, you can add bismuth to Xifaxan as kind of a classic approach. For kind of a more natural herbal approach, you can use molybdenum, which is also, something that you can use just by itself or in addition to kind of a herbal cocktail with other things that are really helpful in SIBO. For example, oregano oil is extremely helpful, as well as working on the root cause. And I think there's a lot of research being done, but SIBO is fairly new. It's a fairly new condition, and it has its own guidelines in our kind of American College of Gastroenterology, but it's in its infancy, honestly. And so everything is kind of just developing. We're starting to just learn the details about it now. I mean, the fact that we only now know there are 3 types, right? So it's really fascinating. It's interesting to keep up with. And there's always kind of a shift in, do you treat it with using possibly like fiber at the same time, or do you treat it and use something like NAC because that possibly might be addressing kind of the mucus barrier? There are a lot of like little studies that are kind of going on all the time. So it's fascinating to keep up with. We kind of just wait and hear what comes out during the conferences.
And so I guess my next question depends on the cause, right? That root cause. If for some of the types of SIBO, is there any familial history that you see? Like if someone has SIBO, a certain type, could their mom have had SIBO, etc.? Like is there some kind of genetic predisposition?
I think that's a really good question. And I don't think that it's ever been looked into yet, because even things like fatty liver, they only recently kind of discovered more of the genetic predisposition and in IBS, right? And the kind of umbrella diagnosis of IBS, they're finding some genes that are associated with it. And so I would imagine there would be, because in, many, again, of these posing conditions, especially with motility, they're, whether it's, autoimmune, and in autoimmune conditions, you have a genetic predisposition and then something triggers it. So I would imagine if they looked into it, there's going to be something. Obviously, like there's these one-offs like the surgeries or taking opiates. There's obviously causes of SIBO that have nothing to do with it. But like, why are some people more predisposed to getting infections when they travel, and that infection doing such damage? They have it for so long. Part of it is like antibiotics and NSAIDs and all the damage we accumulate, right, in our gut journey throughout the years. That's a huge part, right? And I know you take super thorough histories as well, and it's like everyone's gut is just taking hit after hit, right, with antibiotic and infection and PPIs and NSAIDs. And it just, at some point, I think your gut just says, okay, I've had enough. Like this dysbiosis is rooted, right? It's there. Like it's your new microbiome. And that's why why it takes them so long to get to that point. I think there could be, like, let's say, a genetic predisposition.
And that leads me to my final question. What about prevention? What can we do to prevent the development of SIBO? You already mentioned some of it just before, but what else would you recommend?
Take care of your pelvic floor. I see so much pelvic floor dysfunction, and I think some of it is preventable and some of it isn't. For example, when they've had one infection in the gut and they go travel somewhere high risk, such as Mexico, then you can actually take prophylactic treatment with you to prevent another infection, because if you've had one, you're more susceptible to another. And again, it's like that journey of your gut. You don't want to keep hitting it with these insults. You can definitely prevent it that way. You can make sure you're not taking any medications like opiates unless they're absolutely necessary, or antibiotic unless they're absolutely necessary. Always question your doctor, but if it's necessary, it's necessary, then you should take them. But always just question, do you need to take this? Because we know it's gonna take a hit. Your microbiome is really gonna take a hit from these things, especially with chronic use. Take care of your microbiome. It's like every day, just like understand it and what makes it thrive, and just treat it as what people call like their little garden, right? You have to water it and preserve it, because it can go terribly, terribly wrong.
And I'll just touch on the pelvic floor bit that you mentioned, because we didn't get into it too much just yet. But the pelvic floor, it's a collection of muscles that are layered, and they run from your pubic bone all the way back to your coccyx. There's a few openings depending on if you have male pelvic anatomy or female pelvic anatomy. And one of the functions, there's many functions of the pelvic floor, but one of the functions is sphincteric. So there's different sphincters. In addition, there's a support function of your pelvic floor. And when I explain the anatomy of pelvic floor to my patients, I talk about it in relation to the diaphragm. So because the diaphragm, right underneath the diaphragm, our organs are actually suspended. And when we breathe, when the diaphragm is dropping down as for an inhale and then coming back up for an exhale, the pelvic floor is moving with it. And so that's another kind of choreographic moment in our body. And so that's moving together. And so you want to have that movement, one, to balance out the intra-abdominal pressure, but also to allow for that healthy movement in the abdominal space. And healthy muscles in general, they should be able to contract, relax, and lengthen fully. So the same goes for the pelvic floor. And so many times what we find, if there is some kind of, not always, but someone could have hypertonic pelvic floor or just not have the coordination there, and that directly affects the gut health, like you mentioned.
Absolutely. Yeah. And I wonder, for things like ileocecal massage, right? Is that something that you think people can just continue to do? They can use it kind of in their acute phase of treating SIBO, and that maintenance phase, like continue to do visceral manipulation and ileocecal valve massage. People could just continue to do it, right? That could be almost like a prevention.
Absolutely. So one of the things that I commonly recommend to my patients is meditation in general too. But if they have any kind of gastrointestinal health and I'm doing visceral manipulation with them in our sessions, I'll teach them how to warm up their hands and just find the anatomical points where to place their hands, so they can do that as like a meditative grounding technique, but then also as a massage too. It can be done whenever the patient needs it. So, well, this was a really amazing chat, Dr. Ivanina. Thank you so much for your time. Thank you to all the listeners. For those who want to learn more about Dr. Ivanina, her Instagram is filled with a lot of amazing information. And if
Thank
I
you.
get it right, tell me if I have it right. It's gut_love.
Yep.
Am I right? Check that Instagram out, follow her. She's always posting some amazing information and researched backed. So thank you, Dr. Ivanina, and thank you so much to the listeners. Stay tuned next month for another informative chat.
This add-on is being recorded after the live podcast recording. So I had the wonderful opportunity to attend the IPPS conference, International Pelvic Pain Society conference, where a large portion of our discussion for pelvic pain was around endometriosis. Now, we've already had an endometriosis podcast that we recorded, but I just want to add in and mention that there is findings and correlations with gastrointestinal symptoms that sometimes accompanies individuals with endometriosis, and then specifically for SIBO. So this is just a little add-on to say that we are acknowledging for those who have endometriosis that SIBO is commonly found in conjunction with this diagnosis.